Good afternoon, or good morning, or good evening, depending on when and from where you're joining us. I'm Dr. John Iskander. It's my pleasure to welcome you to CDC Public Health Grand Rounds for April 2016, Using Genomics for Cancer Prevention. Public Health Grand Rounds has continuing education credits available for physicians, nurses, pharmacists, veterinarians, health educators, and others. Please see the Public Health Grand Rounds website for more details. Grand Rounds is available on all your favorite web and social media sites. We're also live tweeting today. Use hashtag CDC Grand Rounds. We have a featured video segment on YouTube and our website called Beyond the Data, which is posted shortly after the session. This month's segment features my interview with Dr. Lisa Richardson. We've also partnered with the CDC Public Health Library to feature scientific articles relevant to this session. The full listing is available at cdc.gov/library. The Cancer Family History Guide, which was available in hard copy for those attending in person, is a pocket tool for healthcare providers that helps guide providers' decisions on when further evaluation and genetic counseling is appropriate. Please visit the Michigan Genetics Resource Center to learn more about the tool and to order your own free of charge. Here's a preview of upcoming Grand Round sessions. Please join us live or on the web at your convenience. In addition to today's outstanding speakers, I'd like to acknowledge the important contributions of all of the individuals listed here. Thank you. And now we'll have an introduction from CDC's Associate Director for Science, Dr. Harold Jaffe.
Mercifully, a short introduction. Thanks, John, and thanks to the speakers participating in today's session on the important topic of using genomics for the prevention of cancer. I think you know that most cancers are really a combination of risk factors related to genetics, the environment, and behavior. But some of them are associated with specific inherited disorders that greatly increase cancer risk. For example, we know that over 1 million Americans have either hereditary breast and ovarian cancer syndrome, HBOC, caused by mutations in the BRCA1 and 2 genes, or Lynch Syndrome, which is associated with early colorectal cancer and increased risk of several other cancers. These syndromes increase the cancer risk for affected individuals between 5 and 40 times that of the rest of the population. Nonetheless, persons with these syndromes can benefit from evidence-based interventions for early detection and prevention measures. For example, for people with Lynch syndrome, earlier and more frequent testing could reduce colorectal cancer risk by an estimated 60%, and interventions to identify women infected with BRCA mutations could reduce their breast cancer risk by 85%. In addition, the diagnosis of one of these syndromes can benefit not only the affected individual, but also provide an opportunity to identify other at-risk family members who could benefit from risk reduction interventions. Public health, working with our clinical partners, has the opportunity to make a big difference for persons with hereditary cancers and for their families. And with that goal in mind, this Grand Rounds will highlight CDC's recent work in public health genomics and the innovative approaches taken by state health departments to promote education, surveillance, and policy efforts to address these cancer syndromes. So please give our speakers a warm welcome.
Thank you, Dr. Jaffe. I'd now like to introduce our first speaker, Dr. Lisa Richardson.
Good afternoon, everyone. I'm Lisa Richardson, and I'm an oncologist and the director of the Division of Cancer Prevention and Control. Cancers of the female breast, ovary, and colon and rectal cancer are among the top 10 most common cancers diagnosed in the United States. Colorectal cancer is the third most commonly diagnosed cancer among men and women. Breast cancer is the second leading cause of cancer death among women. Although less common, ovarian cancer is highly deadly, and most cancers are caught late when they are more difficult to treat. Colorectal cancer is the third leading cause of cancer-related deaths among men and women. The risk factors vary for different types of cancers, as noted on this slide. In particular, inherited genetic mutations that increase cancer risk play a major role in about 5 to 10% of all cancers, and the most common hereditary conditions include hereditary breast and ovarian cancer syndrome, or HBOC, and Lynch syndrome. HBOC syndrome involves mutations in two breast cancer susceptibility genes, BRCA1 and BRCA2. These tumor suppressor genes are associated with increased risk of the cancers listed on this slide, with the highest risk for breast and ovarian cancer. About 1 in every 500 women in the U.S. has a BRCA genetic mutation. Lynch syndrome mainly involves mutation of DNA mismatch repair genes, leading to tumors with microsatellite instability. Mutations in these mismatch repair genes are associated with increased risk for cancers of the gastrointestinal and female reproductive tracts, with the highest risk associated with colorectal cancer. Here we see the number and proportion of cancers associated with HBOC and Lynch syndrome. While infrequent, the populations affected by them are sizable. Individuals with these hereditary cancer syndromes are also more likely to be diagnosed at younger ages, at later stages, experience more treatment-related late and long-term side effects, and have greater risk of developing second cancers, whether at the same time, at the same site, or a different one. Each year, HBOC syndrome accounts for up to 10% of all breast cancers, or approximately 22,000 cancers, and 15% of all ovarian cancers, or approximately 3,000. Genetic mutations in DNA mismatch repair genes associated with Lynch syndrome account for up to 3% of all colorectal cancer, or up to 4,000 cases each year. Carriers of hereditary cancer syndromes face a significant cancer-related burden. In these two pictures, the left one depicts 100 women in the general population, and the right one depicts 100 women with HBOC syndrome. Among women in the general population, the risk for breast cancer is about 12% by age 70. Among women with HBOC syndrome, about 65% are expected to develop breast cancer by the same age. The risk for ovarian cancer in the general population is about 1.3% by age 70. Among women with HBOC syndrome, about 39% are expected to develop ovarian cancer by the same age. In the carriers of genetic mutations leading to Lynch syndrome, about 40% are affected by colorectal cancer by age 70, compared to 4% of the general population. Certain family histories are associated with increased risk for HBOC syndrome, including breast and ovarian cancers diagnosed at earlier ages. For HBOC syndrome, family histories are also including a breast cancer diagnosis in a first-degree relative, including breast cancer in men. Approximately 1 in 40 Ashkenazi Jewish women has a BRCA gene mutation, compared to 1 in 500 in the general population. Certain family histories are associated with increased risk for Lynch syndrome, including colorectal cancer diagnosed at earlier ages. Family histories include 1 or more first-degree relatives diagnosed with another Lynch syndrome-related cancer, such as endometrial, ovarian, and stomach cancer, before the age of 50, or 2 or more first- or second-degree relatives diagnosed with another Lynch syndrome-related cancer. Currently, there are 2 genomic testing recommendations for individuals with these hereditary cancer syndromes. The first is from the U.S. Preventive Services Task Force and has a 2-fold recommendation. First, primary care providers screen women who have a family who have family members with breast, ovarian, tubal, or peritoneal cancer to identify a family history that may be associated with BRCA 1 or 2. If women have a family history consistent with HBOC syndrome, they should be referred for genetic counseling, and if indicated after counseling, then BRCA testing. The second is the evaluation of genomic applications in practice and prevention working group, which recommended that people with newly diagnosed colorectal cancer have access to genetic testing of their cancers to identify Lynch syndrome to prevent cancer in their close relatives. Interventions that reduce risk for cancer or cancer-related deaths for individuals who are carriers of hereditary BRCA mutations and Lynch syndrome are available. For HBOC syndrome, these include discussions with the provider and patient about taking risk reduction medicine, such as tamoxifen or raloxifene, if a woman is at low risk for adverse medication effects. While discussions about mammography in the general population don't begin until age 40, women with HBOC syndrome may wish to talk to their provider about having mammography at an earlier age or in combination with breast MRI. Currently, there is no universal screening test available for ovarian cancer. There are 2 prophylactic surgeries that could be used to mitigate risk. A bilateral mastectomy or removal of both breasts can reduce the risk of breast cancer by at least 95%. A bilateral salpingo oophorectomy or removal of the ovaries and fallopian tubes can reduce the risk of breast cancer ranging from 40 to 70%, and the risk of ovarian cancer ranging from 70 to 96%. When patients consider having these procedures, issues that may require discussion include possible physical and emotional side effects and preserving fertility by freezing embryos. Individuals with Lynch syndrome should have discussions with their providers about starting screening colonoscopy starting at age 25 or younger based on family history. Public health practitioners are working to translate and implement recommendations for genetic counseling and testing for hereditary cancer syndromes into practice. These programs work to address challenges and barriers to implementation. Surveillance, epidemiology, and public health research help us track the burden of cancers associated with hereditary cancer syndromes. Communication and partnerships efforts increase awareness and reach, and public health tools and interventions are developed to reach individual providers. We will describe some of CDC's work in these areas in more detail. In 2014, CDC launched the No BRCA Decision Support Tool, which helps women and their providers understand their risk for having a BRCA1 or BRCA2 mutation. The tool provides information to women to guide discussions with providers about family risk. This resource includes a smartphone app and a web-based tool for patients and medical providers to learn more about BRCA gene mutations and assess individual risk for breast and ovarian cancer. Target audiences include young women ages 18 to 44 at high risk for having a BRCA 1 or 2 gene mutation and their providers. CDC launched the award-winning Bring Your Brave digital media campaign in 2015. Bring Your Brave provides information about breast cancer to women younger than 45 by sharing information about hereditary breast and ovarian cancers. This resource increases awareness about breast and ovarian cancer in women younger than 45. Women tell their personal stories about how their lives have been affected by breast cancer. Development of the social media campaign was based on extensive research with target audiences and marketed through Facebook, Twitter, Pinterest, and YouTube. The CDC-funded Public Health Cancer Genomics program provides leadership and builds capacity for cancer genomics activities in state public health departments. CDC funds a 5-year cooperative agreement to implement education, surveillance, policy and systems change activities to translate and implement national recommendations for cancer genomics. Funded programs are working to achieve these goals by developing and fostering partnerships and collaborations with local, state, and national organizations and health systems. You will hear more information about one of these programs from our next speaker. The ultimate objective of the Genomics program is to decrease the morbidity and mortality due to hereditary cancer syndromes. The program seeks to educate the public and providers, develop or expand surveillance systems, and assess systems or policy barriers or facilitators for genetic counseling and testing or risk reduction services. We're going to hear more about how one program is accomplishing these goals from our next speaker, Ms. Deb Duquette from the Michigan Department of Health and Human Services.
Thank you. It is an honor to be presenting today. I am the Genomics Coordinator for the Michigan Department of Health and Human Services and also a board-certified genetic counselor. Michigan is proud to be celebrating over 15 years of our state public health genomics program with a primary focus on hereditary cancers. Our state health department became one of the first in the nation to realize the importance of cancer genetics to improve health outcomes and enhance the quality of life. This was independently recognized by our Cancer Prevention and Control section and their Michigan Cancer Consortium partners, who identified the importance of cancer genetics, especially for risk assessment and referral for BRCA counseling and testing. Additionally, as part of a HRSA-funded needs assessment, the genetics program, which had been focused on newborn screening, learned from our stakeholders that cancer genetics was important to improve the health of the people of Michigan and should be included in our work, leading to our state genetics plan being the first in the nation to include cancer genomics goals and objectives. Our Cancer Genomics program has critical internal partnerships with our Cancer Prevention and Control section, Michigan Cancer Surveillance Program and Vital Records, Medical Services Administration, and numerous external partners that have enabled us to achieve the goals and objectives identified in our state genetics plan, including increasing cancer genetic literacy by expanding public and provider knowledge, assessing the public health impact of hereditary cancer genetic services, enhancing communications with cancer genetic service providers and promoting partnerships, and most importantly, reducing morbidity and mortality related to hereditary cancer by increasing utilization of appropriate cancer risk assessment services, which is the ultimate long-term goal of our Cancer Genomics program. We are also proud of the Michigan Comprehensive Cancer Control Plan that was the first in the United States to have an entire goal for cancer genomics. The Michigan Cancer Consortium has over 100 organizations that have worked on this state comprehensive cancer control plan to increase the availability of cancer-related genetic information to the public and decrease barriers to risk-appropriate screening and treatment services. Additionally, these organizations have worked on the ovarian cancer goal to improve access to genetic counseling services for women who are at high risk. A new comprehensive cancer control plan has just been released that includes several specific and measurable cancer genetic objectives and strategies for the next 5 years. Our cancer genomics activities have been significantly enhanced because of several cooperative agreements with CDC. The first 5-year award in 2003 sought to integrate genomics into chronic disease programs. The next award was in 2008 with the purpose of moving evidence-based genomic applications into health practice to maximize health benefits and minimize harm. It was this cooperative agreement that led to our successful approach of using the core public health functions of assessment, policy, and assurance to promote cancer genomic best practices. We were especially successful in developing and implementing surveillance for Lynch Syndrome and BRCA1 and 2 mutations using new and existing data sources, such as our state cancer registry and the Michigan Behavioral Risk Factor Surveillance System. We also developed provider education tools to increase use of appropriate screening, counseling, and testing, and identified model health plan policies for appropriate BRCA counseling and testing. In 2011, Michigan was awarded by CDC to enhance and expand our policy, surveillance, and provider education activities related to BRCA counseling, testing, and management. This cooperative agreement required funded programs to conduct policy activities for breast cancer genomics. We therefore structured our provider education and clinical and public health surveillance activities to utilize health plan policies as the catalyst to maximize health benefits of appropriate BRCA-related services and minimize potential harms. We envisioned BRCA clinical practices as 4 critical steps, starting with accurate recording of family and personal history of cancer, followed by appropriate cancer genetic risk evaluation and referral for BRCA counseling for at-risk individuals. Next, followed by BRCA testing for consented patients with accurate interpretation and discussion of results. And finally, for individuals found to have a deleterious mutation, appropriate delivery of BRCA-related clinical services. Since the inception of our cancer genomics program, the Michigan Cancer Surveillance Program has been instrumental for several activities, including monitoring the number of cancer diagnoses appropriate for Lynch syndrome screening and hereditary and breast and ovarian cancer assessment, cases examined using our state cancer registry and vital records data include multiple primary cancers, breast cancers diagnosed at a young age, triple-negative breast cancers, and males with breast cancer. Over 15,000 cancers diagnosed in a 2-year period in Michigan met this case criteria to be appropriate for hereditary cancer screening. This information has been used to disseminate individualized reports back to the reporting facility and provider with information on how and where to refer cases for clinical cancer genetic services. With the Michigan Cancer Surveillance Program, we have also conducted quality assurance chart audits to assess cancer family history documentation, Lynch syndrome screening, and BRCA counseling and testing. These chart reviews have identified areas for improvement, including family history documentation, especially for age of onset, and the need for increased referrals for BRCA and Lynch syndrome counseling and screening. Based on these findings, family history documentation has been added as a mandatory reporting element for facilities in Michigan. With CDC, the Michigan Cancer Surveillance Program, and the University of Michigan, we also conducted a study of 3,000 young breast cancer survivors and their at-risk female relatives to determine barriers and facilitators to breast cancer screening and cancer genetic services. We also provided written interventions to increase these services. This study demonstrated significant health disparities, with the baseline survey finding only 18.3% of Black young breast cancer survivors receiving genetic counseling and testing, compared to 32.9% of other young breast cancer survivors. The most common self-reported reason for not seeking cancer genetic services was that no one had ever suggested these services. This was reported for 75% of Black young breast cancer survivors and 63% of other young breast cancer survivors. In order to increase provider awareness and education about appropriate referrals for BRCA counseling and testing, Michigan partnered with CDC, other state grantees, and local partners to develop an online CME course. Participants learn BRCA best practices through an engaging and interactive online approach that includes a variety of clinical cases with different decision options, risks, and outcomes. Participants can receive 2.0 CMEs at no cost. This online course has had over 4,400 sessions viewed, with the majority of participants reporting that the course will change their practice for BRCA counseling and testing. We have also developed provider tools to assist with risk assessment and referral for cancer genetic services and cancer screening management. One of our most popular tools is the Cancer Family History Guide, which has been sent to over 20,000 providers at no cost. Michigan has had significant annual increases in the number of individuals who receive BRCA counseling, were tested after counseling, and receive BRCA positive results at cancer genetic clinics with board-certified genetic counselors. This increase is related to several factors, including provider education efforts and a significant growth in the number of cancer genetic clinics with board-certified genetic counselors, many in previously underserved areas, and the availability of telephonic genetic counseling services. However, there continues to be a need for cancer genetic services for specific populations. For instance, less than 300 Black adults per year in Michigan are receiving cancer genetic counseling services, with little increase seen between 2008 and 2013. For our new cooperative agreement, populations in need of greater cancer genetic services are a primary focus, including Black adults with a significant personal or family history of breast and ovarian cancer. Another activity that has helped to increase access to BRCA counseling and testing is our work to recognize and promote best practices for health insurance plans. We developed metrics for BRCA best practices based on evidence-based recommendations and reviewed each health plan's written policies. Once a health plan received thumbs up for all metrics, they were recognized by our department. Annually, our program has provided each health plan with an individualized report indicating areas of improvement if needed, data about the number of their members receiving BRCA counseling and testing by clinics with board-certified genetic professionals, examples of best practice written health plan policies, and a directory of Michigan Cancer Genetic Services. When this work began in 2009, there were only 4 of 25 Michigan health plans that were recognized for their written policies. And now to date, we have recognized 16 of our health plans that provide coverage to over 8 million people in Michigan. For many of the health plans, annual growth in the number of their members receiving BRCA counseling has been found. Additionally, we have shown reduced insurance barriers to appropriate BRCA testing in our clinical surveillance data. CDC has used this as a model to investigate BRCA written health plan policies in other states. With CDC's support, we also founded the Lynch Syndrome Screening Network, whose mission is to promote Lynch syndrome screening on all newly diagnosed patients with colorectal cancer. If your institution is interested in partnering to promote Lynch syndrome screening for newly diagnosed colorectal cancers, please consider joining the network. This is a national organization with over 120 leading cancer institutional members that have reported over 20,000 newly diagnosed colorectal cancers screened for Lynch syndrome, with significant annual increases since 2009. In summary, there is an overall need to increase evidence-based cancer genomic best practices for all populations and to address identified health disparities. State health departments are well poised to promote such practices and have the infrastructure to do so. Partnerships and dedicated staff can help tremendously to advance cancer genomic activities that utilize the core public health functions of assessment, policy, and assurance. Please contact me if you are interested in learning more or obtaining any of our educational, surveillance, or policy resources. Thank you so much, and the next speaker is Lindsay Avner, who is the CEO of Bright Pink.
Thank you so much for allowing me to join you here today. My name is Lindsay Avner, and my story started back before I was born. I have a very, very, very strong family history of both breast and ovarian cancer. My grandmother and great-grandmother passed away 6 days apart, both from breast cancer, at the ages of 39 and 58. When I was 12, my mom was diagnosed with breast cancer, and 10 months later with ovarian cancer, and I'm so thrilled to share that she is a 24-year breast, 23-year ovarian cancer survivor today. And as you can imagine, I always felt as though this disease or these diseases would be coming for me at one point, but it would be years and years from now. Although I was surprised after graduating from the University of Michigan when I found out that I tested positive for the BRCA1 gene mutation in 2005. I was shocked, I was scared. I reached out to a whole bunch of cancer organizations and found I didn't really fit within that group, and yet I wasn't like everybody else. Oops, I'm so sorry. I would go to these screening appointments and I would hold my breath hoping that everything would be okay, walk out, breathe a sigh of relief, but no, I had to turn around and do the screening once again. And through my entire experience, I realized that I was playing a big game of defense and not offense. And so in 2006, I opted to have a risk-reducing double mastectomy. At the time, I was the youngest patient in the country ever to make this decision. And it was through this experience that I realized the lack of resources out there for young women like myself, women who are healthy, but had the power to be proactive with their health. I was asking myself this question, which was, why do we have to wait until someone is diagnosed to take action? And so in 2007, Bright Pink was born. Bright Pink is a national nonprofit organization focused on the prevention and early detection of both breast and ovarian cancer in young women. We see a world in which fewer people are dying from breast and ovarian cancer, and we aim to reach them at a young age and inspire them to take action. Everything we do is focused on empowering them with information and access to resources and tools, getting them to do things, to be proactive with their health, to go to their doctor, to examine their family health history, to have this conversation with women in their life that they love. And we do this by reaching the 52 million women in the U.S. between the ages of 18 and 45, as well as the healthcare providers who care for them. We're reaching them with evidence-based breast and ovarian health content in a whole variety of ways. I'll tell you about some in just a moment, but we're reaching them in particular where they work, where they're connecting digitally, where they're engaging with their community, and the whole focus is inspiring them to put awareness in action. We sit on the decades of massive awareness movements, and yet we find that that same woman who might show up and run a 5K has no idea that her father's side of the family history matters just as much as her mother's, and we're aiming to change that. There are education programs that are focused on scale, reaching millions of women, and sustained behavior change. It's a two-pronged approach to our work. One side of the organization focuses on empowering women. The other side focuses on ensuring that we have proactive providers, and together this is a life-saving equation. And we have broad reach. We are currently operate within 39 different states. We have coverage of Bright Pink trained ambassadors who go into their communities, into workplaces, into places of worship, and they're educating women and offering unmatched support. We couldn't do it alone without these thousands of people who are joining us in bringing this mission to life. And so to touch just upon how we're doing this, specifically as it relates to young women, we have an incredible workshop that is about 20 minutes. It's called our Brighten Up. And what we do is we go into places where young women are. We teach them about the role that family health history plays in determining their own risk. We walk through early detection practices, signs and symptoms, risk reduction, risk assessment. And ultimately, the end call to action is our digital risk assessment tool. But you can see with the educational workshop, last year alone, we had the opportunity to reach more than 35,000 women. This year, we're on track to double that, to reach more than 70,000 women with this high-touch program. The digital complement to this program is a 19-question quiz that we call Assess Your Risk. It combines family health history with lifestyle factors and gives a user a preliminary sense of, do they fall within an average risk, increased risk, or high risk category, what's working in their favor, what's not, and what they can do as a result. And you can see we were so proud last year to have more than 120,000 women complete this risk assessment. And this year we're on track to close to triple those results. For those women who find out that they are at high risk, who carry a mutation, we have a whole variety of support offerings. Pink Pal is operated by a psychologist on our staff who pairs up a young woman perhaps considering genetic testing with another woman who's already of similar demographics who's already gone through a similar situation. We have outreach groups in 23 communities. These are gatherings of high-risk women to share similar concerns and experiences, and we also have a whole digital presence of people who prefer to sit from the comfort of their home and connect with others. And we're really proud later this year to be launching a new microsite that's focused on being a one-stop shop for all information related to genetic testing, to really demystify this process and inspire women who should be getting testing to cross over, obviously responsibly through visiting a genetic counselor and ensuring that they are prepared to handle those results. We know that this is working. This is a quote from one of our ambassadors, so one of the women who goes out into the community in Dallas and educates. She said, after this talk, I was approached by a young woman who shared her striking family history of breast and ovarian cancer. She was relieved that there was genetic testing for her family. We also heard just a couple weeks ago from Katie, who wrote to us on Facebook, and she said, thank you for providing accurate and evidence-based information on cancer risk. I knew that I carried the BRCA2 mutation, but the information you provided helped me decide to undergo a prophylactic double mastectomy 6 weeks ago. I am now a success story, and that's what it's all about. On the other side of the organization, as I mentioned before, we focus on reaching providers, OBGYNs, internists, family medicine practitioners, nurses as well. And the whole program was developed based on this insight and this constant conversation we're hearing from members of our community who are saying, you educated me, I went to my provider, and I actually knew a little bit more than they did. And what we realized is there was this tremendous gap that existed in ensuring that providers knew that risk is not binary. It's not you're either at risk or you're not. It's a spectrum, and how to properly classify women based on risk and manage that risk as a result. So we've trained close to 50 medical providers nationwide who we send into grand round settings in residency didactics. It's a 50-minute lecture accompanied with a case-based learning module. In 2015, we were so proud to educate more than 4,000 providers at more than 80 institutions. And we all know these are very busy people who are seeing a lot of patients. So the exponential impact of this work is the power to reach more than 14 million women in the year to come. What I think is so incredible about this, though, is that the providers are walking out, whether we're reaching them at prestigious institutions or community health settings, and they're telling us that this program is making a difference. And you can see this year we're on track to reach more than 6,000 providers at more than 100 institutions, more than 21 million women seeing the benefit, and we're also working on a digital component to this. So the program evaluations have been quite revealing. 89% of providers are citing an increased knowledge on how to correctly classify the risk level for their young female patients as a result of this program. You can see from the chairman of family medicine at the Cleveland Clinic saying, thanks for an interesting practical grand rounds this morning, already starting to change the way I think about screening some of my patients. More data, 84% of our providers are indicating that they had an increased knowledge of breast and ovarian cancer risk reduction and early detection options for young women as a result. And I love this quote from Dr. Redman, who said, this lecture really gives the right perspective. It breaks it down. It's more than studying for the boards. It's the heart of practicing. We know that 99% of people who are attending these workshops also say that they would either agree or strongly agree to the statement, I feel a sense of urgency to initiate conversations about breast and ovarian cancer risk with my young female patients as a result of this program. And that is that sustained behavior change. We're also following up with 3 and 6 month data to ensure that it's really sticking. So it's interesting because I started this talk sharing with you a little bit about my history, my background, the past, and that inspired me. And yet what really moves me today is the possibility for the future. The reason I do this work is because I have 3 teenage children that are absolutely counting on me, and they're counting on all of us to create the world that we want. I met my husband, Greg, 6 months after his late wife, Felicia, had passed away from breast cancer. Everyone said she was an amazing woman. She was actually diagnosed with breast cancer at 35, and only afterwards did she find out that she was BRCA positive. I have 2 stepdaughters and a stepson that may be carriers, and I have a vision for the world I want for them to grow up in. And it's a world where their provider is educated, it's a world where they feel supported to make healthy decisions, and it is a world where they are playing offense and not defense. And I know that this world can be possible because of the work of Bright Pink, because of the work and dedication of all of the work that each and every one of you do as well. So with that, I would encourage all of you to visit brightpink.org to get involved in our programs, offering assessyourrisk.org as an option. And I thank you so much. With that, I'd love to introduce you to Dr. Corey.
Good afternoon. You've heard what CDC and state public health programs are doing in using genomics in cancer control and prevention. Cancer has been the leading application for public health genomics. but genomics truly applies to all human diseases and affects all areas of public health. Almost 2 decades ago, CDC realized the profound opportunities and challenges for genomics in public health and created the CDC Office of Public Health Genomics. The office has been working with CDC programs, state public health, and other partners to effectively and responsibly translate genome discoveries into disease prevention and population health. We have 3 main strategies: identify evidence-based genomic applications, inform and communicate with providers, policymakers, and the public, and integrate these applications into clinical practice and public health programs. A crucial function in public health genomics is to identify health impact in a rapidly emerging landscape of science and technology, specifically identifying which genomic applications and family history that are supported by synthesized evidence for their use, estimate the potential population health impact, which can be measured in terms of life saved, disease prevented, and healthcare cost savings, and finally, promoting appropriate and equitable use. This public health assessment function is needed more than ever as we continue to see amazing growth in the number of available genetic tests in the past 2 decades. As of March 30th this year, there are over 78,000 genetic tests for more than 4,000 diseases available through clinical research and practice. Almost 700 labs and more than 1,000 clinics are offering genetic testing for many diseases and conditions. What should be the appropriate public health response? To identify genomic tests and applications that are ready to impact health now, CDC has developed a simple classification schema for genomic tests based on rapidly changing levels of evidence. Tier 1 or green are ready applications that can be implemented today in practice. And you've heard 2 prominent examples today: hereditary breast and ovarian cancer and Lynch syndrome. But there are also other things like newborn screening, which has been a prominent public health genetics program for more than 50 years. Tier 2 or yellow are applications for which there is insufficient evidence to support routine implementation, but they can provide information for informed decision-making on a case-by-case basis. This category includes, for example, many of the 200 pharmacogenomic tests that are on the FDA gene drug label. These tests are used for the prediction of patients' response to certain medications. Tier 3 or red are applications and tests that are not ready for routine implementation because they either lack evidence or there is enough evidence to recommend against their use. An example of Tier 3 are direct-to-consumer personal genomic tests. Summarized, today there are more than 40 Tier 1 tests classified to date. Most of them are cancer-related. Their intended uses vary from diagnosis, prognosis, risk prediction, treatment, risk assessment, and pharmacogenomics. In fact, genomic applications today in Tier 1 could benefit millions of people. Other than newborn screening, which affects all births, the 2 conditions discussed today are estimated to affect more than 1 million people in the United States. And most of them do not know they have these conditions. This calls for an important role for public health in saving lives and preventing disease. You heard about one low-tech genomic application or tool that's ready for use in public health today. That's family health history. We know that family health history is a risk factor for many diseases. Use of family history offers opportunities for targeted screening and evidence-based interventions that can save lives and reduce the burden of many chronic disease, in addition to cancer, diabetes, and heart disease, for example. Public health approaches to use family history are already in place. For over a decade, CDC has been part of the Surgeon General Family Health History Initiative, which has developed an online free family health history tool available in 4 languages to encourage all Americans to collect family history information, especially around holidays when families gather. Thanksgiving Day has been declared by the Surgeon General the National Family Health History Day since 2004. So where are we now with genomics and public health, and what does the future hold? The possibilities for genomics to improve public health are growing rapidly. More than a decade after the completion of the Human Genome Project, genome sequencing is cheaper and more reliable than ever. Whole genome sequencing has emerged as a powerful tool in both clinical and public health. Human DNA sequencing is increasingly used for the diagnosis of rare disease and tumor sequencing. Pathogen DNA sequencing has become an essential public health tool. The recently launched CDC Advanced Molecular Detection Initiative uses genomic technologies and bioinformatics and surveillance and outbreak control and detection. We've also seen increased public awareness and use of genetic tests, such as the increase in Brca testing that followed Angelina Jolie's announcement about her own status and prophylactic surgeries. Last but not least, we are seeing a rapid proliferation of direct-to-consumer genetic tests by the private sectors. 1 million or more people have already sought such services in a changing paradigm of how genetic testing can be done. Supporters of direct-to-consumer testing praise it for allowing consumer empowerment. Others have expressed concern that such testing does not adhere to evidence-based applications and best practices, and certainly the use of genetic counseling before testing. Increasingly, a public health approach is needed to address challenges in genomic implementation across many diseases. You've heard about education of the public and healthcare community, addressing healthcare systems limitations, such as collecting family health history, and approaches to inform affected patients' relatives of their risks, promoting evidence-based policy and practice to support the appropriate use of genomic tests and reducing healthcare costs, collecting, analyzing population-level data on implementation and outcomes, and assuring the lab quality of such testing, and last but not least, addressing health disparities to ensure benefits for all. The potential for widening health disparities in the genomics era is real. This is just one example of a study that illustrates disparities in BRCA testing by racial ethnic groups. This is a study of early onset breast cancer cases in young women from a national sample of about 14 million commercially insured patients. You can see that Black and Hispanic women are significantly less likely to have BRCA testing compared to white women. Not only do these women miss out on the benefits of testing in terms of their own management, but their family members also miss on the chance to find out if they're at risk. These types of data should be looked at across all genetic tests and disease conditions, and reasons for disparities explored and addressed. Genomics is also increasingly addressed in national policy and legislation, including the Affordable Care Act, which now covers some evidence-based genomic services, such as BRCA, in accordance with the U.S. Preventive Services Task Force recommendation, as well as newborn screening. The Genetic Information Non-Discrimination Act, or GINA, prohibits discrimination in health coverage and employment based on genetic information. The inclusion of specific CPT codes for many genetic tests now allows us to track implementation and outcomes of genetic testing in the United States. And last but not least, HHS Healthy People 2020 objectives have added 2 new genomic objectives: hereditary breast and ovarian cancer and Lynch syndrome. To summarize, you've seen this slide before in the context of cancer genomics, but truly applies to all areas of genomic activities in public health across numerous disease programs. This includes surveillance, epi and research, communication and partnerships, and public health practice. Finally, I'd like to end with a unique emerging opportunity for public health. In 2015, President Obama launched the U.S. Precision Medicine Initiative. This initiative promises a new era of targeted treatment and prevention across many human diseases. The initiative has 2 components: development of new cancer molecularly targeted therapies, and a national cohort of 1 million or more people, which seeks to prospectively study genetic and non-genetic factors in health disease and other outcomes on a very large scale, and also to use this information in developing new therapies and preventive interventions. How is this initiative relevant to public health? The success of the Precision Medicine Initiative requires a strong public health partnership to help ensure inclusion and generalizability, and a focus on prevention, not just treatment. Public health is also needed to ensure an appropriate balance between long-term knowledge generation and immediate health gains within the cohort that are possible by implementing existing evidence-based genomic applications, such as the ones discussed today and others from the Tier 1 CDC list. In the future, we can look forward to a new era of precision public health, in which health interventions can be targeted to population subgroups based on genetics and other factors, to maximize benefits of prevention strategies, minimize harms, and reduce healthcare costs in the 21st century. Thank you for your attention.
is, would the panel please address the perception that people may have that if they don't have the genes for a particular cancer, they are safe? That really needs to be accounted for.
Mooney, do you want to start with that?
I mean, you've seen the slides, actually. These slides had the risk of breast and ovarian cancer and colorectal cancer among people with or without carriage of these types of mutations. And if you are negative for BRCA1 or 2 or Lynch syndrome, you still have a background risk of breast, ovarian, and colorectal cancer. That depends on other risk factors, depends on your age, on other considerations, and maybe other genes that haven't been measured yet.
Dr. Jaffe?
I know that the direct consumer marketing of these genetic tests is rated, I guess, as tier 3, but presumably people are getting these tests. Are they turning up to genetic counselors holding their test results and saying, am I going to get breast cancer?
Yeah, do you want to take that?
Yes, that's correct. So you are exactly correct that that is happening in the genetics clinics as well as in the primary care provider clinics as well, that people are bringing those test results very confused about what they mean, and then also the providers need to try to figure out what's going on with that. Interestingly enough, in Michigan, we're one of the very few states in the United States that we have a law that's been in place since 2000 that requires written informed consent to be obtained by a provider before any pre-symptomatic or predictive genetic test, but it would only apply to things that happen in Michigan. So it's certainly, when we've looked at data from our behavioral risk factor surveys and compared it to other states, Michigan, we do seem to have way less awareness of that, and it may be somewhat related to that law compared to other states. So we're perhaps not seeing it as much in Michigan compared to other states, but we are definitely seeing it.
Just to add to what Deb just said, a recent study of 1,000 customers who had these services, and within 6 months, about a third of them took to their providers, and many of them emerged back from the provider interaction dissatisfied or unhappy of that interaction because the providers didn't know what to do with the information. So it's a confusing market out there. There are other reasons why people do DTC testing, like ancestry and recreation. I mean, they have fun. They like to do other things. But for health-related purposes, we call them tier 3.
So Lindsay, did you want to say anything as someone who's been tested?
Yeah, I think this is a hard handle, right? In some ways, you're getting access to information. I'm so sorry. Gosh, guys, I'm not working the technology so well. As somebody who is talking to women day in and day out about this information and trying to get them over this really critical hurdle. There's so many people that should be getting tested that aren't. So in some ways, creating greater access is really exciting in a lot of ways, but it's also can be scary, right? We need to make sure that we're doing this responsibly, that when people get the results, that there's a huge uptake in terms of doing something with those results. We very much believe, we talk about this all the time at Bright Pink, that it's not just about knowledge, it's not just about awareness, it's about what do you do as a result of that. And so I think having a really thoughtful partner in your provider, which is why the program Bright Pink is going out and delivering in communities nationwide is so critical, because we need to make sure that these providers are totally equipped to have this conversation to support the action that drives out as a result.
We'll take a question from the online audience.
So from our Grand Rounds email box, Dr. Richardson advocates genetic counseling for individuals who may have increased risk for cancer. According to a recent report on National Public Radio, however, the current number of genetic counselors is inadequate to meet this need. Could Dr. Richardson or other speakers comment on, 1, the adequacy of the number of genetic counselors compared to the number of people who seek or need genetic counseling, and 2, national efforts to increase the number of genetic counselors?
So we also heard that story on NPR yesterday, and we thought it was quite timely for today's presentation. There is a shortage. There is a shortage of genetics counselors who are board certified, and Deb can speak to that. I think some of the things they're doing in Michigan that they're doing in other places is telephonic counseling. Telehealth is now, becoming bigger and bigger, so you can reach audiences or people in need who don't have counselors where they are. I am not aware, and Deb may know more about it, how training is being ramped up to have more counselors trained.
So yes, you are correct. The American Board of Genetic Counselors and National Society of Genetic Counselors have definitely been trying to think of ways to get to increase the number of genetic counselors. One of the issues is that the genetic counselors are moving from clinical practice into industry, and so to keep those genetic counselors in clinical practice, new things are happening like increases in salary, which is a very good idea, but also programs are really trying to increase their capacity. For instance, I'm a Northwestern University graduate of their genetic counseling program. This year they had 13 graduates, but next year they're taking 20.
The only other thing I will add is that I think it's just really important to make sure that we're thinking about where, especially young women are, and offering the information, how they're used to receiving content. And I think part of our efforts to create a digital one-stop shop, so to say, that really demystifies this process. I think because we do know sometimes when people are referred to genetic counselors, that middle step can actually be a hindrance in itself. So I think this is a really tricky, evolving situation where we all need to be watching it, but also be focused on the end goal, which is ensuring that the 90% of people in this country who carry a BRCA mutation have access to find out this information and therefore do something as a result.
We have time for one more question in the room. Rich?
Thanks, and really good and useful presentations by all four of you. Appreciate that. So I'd like to talk about one group, Ashkenazi Jews. On a personal note, I was born and raised Jewish. My sister and mother had breast cancer, both BRCA negative, which makes life more difficult in figuring out what the risk factors are, as someone else pointed out here. Since Ashkenazi Jews are disproportionately affected, or more likely to have BRCA genes, what is CDC doing? What are states likely to do? What do we support the states to do? And what avenues are you looking at? And I'll just name a few and then go away. So one is that Jewish women typically are very tightly bound to their parents, even beyond marriage. And the mother commonly is in a sisterhood at her temple. So that's one thing. Another situation is there are colleges that are relatively high percentage Jewish women population. I'm told Emory is like 1/3 total men and women Jewish. So that's another target. And since we're talking about the proper targeting and communication, I wonder if we've started to make that attempt. So thank you, however you take it.
Thanks, Rich. So to answer your question, we have been working with several Jewish groups, Sharet for one in particular. So we have identified that as a population to which we reach out to specifically. Don't have time to go into all the details, but I'll be happy to talk with you later. But yeah, we have recognized that as a specific need. So I think that's all the questions that we can take. I'm sorry, one more? Okay.
Again, from our Grand Rounds email box, this one's a little broad. What are your recommended strategies for public health organizations to provide education, screening, and referrals for BRCA 1 and 2 testing?
So Deb, that's right up your alley. I'll let you take it or start.
I'm a huge advocate of epidemiology and data, and starting there to really try and figure out where the needs are in your community, and then to target your education efforts based on that. Otherwise, I think it's going to become way too broad and not so focused. But one easy target is if your state does have a large Ashkenazi Jewish population, that would be a very easy place to start. So that would be my number one focus for people. But it does seem when we look at our data, and I would encourage people to look at this, is really look at the ovarian cancer cases, because I think that is a very, very important group that definitely needs these services, and that all ovarian cancer patients would greatly benefit for this. And the fact you're going to find something, either Lynch syndrome or BRCA or another hereditary cancer syndrome in that population, is going to be much greater than other populations.
So I'll end with the fact that you're watching this telecast right now is the beginning of learning about what your options are and becoming educated about your options. All the things that we've talked about here today are critical, and the main thing is, I think it was, Rich may have said it when he was speaking, you know, family history, even without a gene, is really what this is all about. So understand your family history, understand what your options are for testing, counseling and testing, and then, you know, empower yourself, as Lindsay said, to move forward and figure out what to do about your risk.
Thank you all very much. Can we have another round for our outstanding speakers? So I actually used the wheel to log in my own family history, and thankfully my provider is actually screening me appropriately. So I'm very happy to have confirmation of that. This is a great tool, and again, please join us in next month for another edition of Public Health Grand Rounds. Thank you.